Hello, everyone. Welcome back to segment two of our recording. So let's move forward. Here are the objectives again. So we left off at McLeod and I on the last segment. So we will continue on our journey to explore more diabetes medication. Starting this segment with incretin-based agents. So there are three subclasses of agents in this category. They are DPP-4 inhibitors and their tablets, GLP-1 receptor agonists, and amylin mimetic. So they both are injections. So what's so cool about GLP-1 receptor agonists? So just this single class would target 6 out of the 8 core defects. So they are the core defects include liver, pancreas, so alpha and beta cells, skeletal muscle, the brain, and also the gut. So all of them, they work in a relatively new pathway called the incretin effect. So I will explain what that means in the next slide. So incretin effect. Incretin stands for intestinal secretion of insulin. So usually it occurs when the polypeptides are released from the gut when we ingest a meal. So what's cool thing about this is that more insulin is being produced with the same load of glucose from orally more than from the IV route. So as I mentioned earlier, there are three subclasses, and they include the oral and also the injectables. So let's get into a little bit of how this pathway works. So let's start with, so we eat something, and the food gets into our GI tract. Then in the GI tract, there are some proteins or peptides are being produced. So they are the GLP-1 and also GIP. So GLP-1 stands for glucagon-like peptide 1, and GIP stands for glucagon-dependent insulin-tropic peptide. So, and later on, these two peptides will stimulate the pancreas, beta cell, and also alpha cell to increase the glucose uptake by the muscles or by reducing glucose production by the liver. However, let's go back to the beginning. So, however, these two peptides can be relatively degraded, rapidly degraded by an enzyme called DPP-4. So there's the class DPP-4 inhibitor will specifically target the DPP-4 enzyme to increase and hopefully can increase the concentration of GLP-1 and GIP to keep the normal physiological process. And the GLP-1 receptor agonist specifically to just help increase the concentration of GLP-1 in the system that will help ultimately to reduce glucose. FYI slide. So I just want to show here it's the GLP-1 and also GIP are being produced by the different sections in the GI tract. And as I mentioned earlier, they will be degraded very rapidly by DPP-4. So that's the reason why that we have a medication class specifically invented to stop the action of DPP-4. And so let's talk about DPP-4 inhibitors. In terms of the name of the drugs, so whenever you see gliptins, and so they are an agent of DPP-4 inhibitor. So the good thing about this is a once daily dosing, and we usually can start with the max dose. So there are 4 agents in this class. They are sitagliptin, saxagliptin, linagliptin, and alogliptin. So one thing I would like to point out about saxagliptin, many of the all of the diabetes drug now that we have to go through a cardiovascular outcome trial to prove that there's no harm to the patient in terms of cardiovascular outcomes. So, but for saxagliptin, um, their cardiovascular outcome trial found out that there were a higher number of heart failure cases leading to hospitalization um, from those who are on saxagliptin. So the underlying message here is if you encounter a patient who have any form of heart failure, then do not use saxagliptin. Um, and in terms of the way how DPP-4 inhibitor um, secrete insulin, so this is pretty cool here. So they secrete insulin through a glucose-dependent manner. So what that means is if the patient's glucose level is higher, and the medication respond to that, and by working it harder, and to produce more insulin to help control the sugar. So with that special property, this class of medication um, is associated with a relatively low risk of hypoglycemia. And also, they would impact both insulin secretion and also glucagon secretion. So let's just recap on how this medication works. So DPP-4 inhibitor would mildly reduce the breakdown of the peptide that are produced after we eat. And these peptides are GLP-1 and GIP. So by doing that, and the endogenous GLP-1 concentration can be maintained or prolonged. So by blocking the enzyme of DPP-4, and we will hopefully see an increase of GLP-1 concentration by 2 to 3-fold. So what is the use by having a higher GLP-1 level in the gut? So first, by having a higher GLP-1 concentration will lead to the increase of insulin from a glucose-dependent manner, and also it would help decrease the glucagon level. And for DPP-4, they would help with the postprandial glucose excursion, and also it would help with the fasting glucose management. The good thing about this class is they have no effect on the GI motility. So the reason it's, due to that, then we won't see much, because they do not impact much on the gastric emptying. Another cool thing about this class would be they do not impact patients' weight. And one point that I would like to point out, this class might be favorable in those who are older, and that means they're more prone to hypoglycemia. So what are some side effects? So DPP-4 inhibitors, they're very well tolerated, but we might observe some upper respiratory tract infection or some skin reaction to the medication. And there are some rare side effects that have been identified. There's severe joint pain and also pancreatitis. There are some warnings for this medications though. So for those who have type 1, we don't want to use this medication. Type 1 diabetes, we don't want to use this medication. And most of the agent are renally cleared, except linagliptin. So for those who have really low renal function, consider linagliptin. Also, for those who have history of pancreatitis and who drink a lot, then this class might not be the best for them. And also because DPP-4 inhibitor and GLP-1 receptor agonists, they act on the same pathway. So do not use both class at the same time. And for those who are pregnant, and we can consider using this class as well. So this is just a table to show you how you might want to dose this medication based on their renal function. So as I mentioned earlier, sitagliptin, saxagliptin, and alogliptin, you will need to dose according to their renal function, except linagliptin. In terms of A1C reduction, they're not that potent to reduce A1C. So at most, probably you see a 0.7% reduction. And to be more specific in terms of controlling blood glucose, if you want to see a drop or control postprandial blood glucose, you might want to consider a DPP-4 inhibitor for a patient. So again, this is just a summary slide, and I want to point out two things. So in terms of dosing, this is a once daily dosing medication class. And also, for those who have history of pancreatitis, you don't want to use this medication. So the next class is GLP-1 receptor agonist, and I gotta say, this is my favorite class. So let's get to it. So how do they work? Pretty much, you inject GLP-1 into the body, and they will work as a GLP-1, and hopefully we will see an increase of GLP-1 concentration by 6 to 10-fold. So how do they work? First, they will stimulate insulin secretion, again, the same as DPP-4, in a glucose-dependent manner. So with that said, GLP-1 receptor agonists will help reduce fasting blood glucose, postprandial blood glucose, and also A1C. Because they act as a glucose-dependent manner. So we will see a lower rate of hypoglycemia. And also, we will see a lower concentration of glucagon due to the reduction glucagon in the body, and which then will lead to a lower glucose being produced from the liver. And this agents will suppress appetite, and this is the golden statement that you can share with your patient. Since this is an injectable, so many patients, when they hear injectable, most of them, they're reluctant. But then as soon as you say, okay, this can lead to weight loss, and many of the patients, they will tell you, oh, sign me up, I want that. And the next effect of GLP-1 receptor agonists would be they would slow down the gastrointestinal emptying. So they will help lead to the decrease of postprandial high. There are 7 agents in this class available at this point. So they are exenatide. Exenatide, there are 2 formulations. There is an immediate release and extended release formulation. Liraglutide, albiglutide, dulaglutide, lixisenatide, semaglutide. So semaglutide just approved last month. So one thing that I would like to point out, liraglutide or Victoza, there is a new indication. So liraglutide will not only be used for diabetes, it can be used for something else. And I will have a slide later on to talk more about this. So in terms of dosing, one thing I would like to point out though, the 4 out of the 7 agents, they're just once weekly. So this is very convenient. So they are exenatide, extended release, dulaglutide, albiglutide, and semaglutide. They're all once daily. And we have liraglutide and lixisenatide. They're once daily. Then lastly, exenatide, the IR formulation, then we have to do it twice daily. So for renal dosing, we have to pay attention. So for liraglutide, dulaglutide, albiglutide, and semaglutide, so we don't have to worry about renal dosing. So pay attention when it comes to, for those who have reduced renal function. In terms of hepatic adjustment, so we don't need to. So there's no recommended adjustment, but we have to pay attention if for those who have reduced hepatic function. So one thing I will point out here, lexacenatide and exenatide, the IR formulation, they have a they can help to reduce a postprandial glucose more than the other agents. However, when it comes to the long term, so they have a smaller A1C reduction than the other agents. In terms of side effects, the biggest side effect is really nausea, vomiting, and diarrhea. So the reason is because this agent will reduce the gastric emptying and to induce the loss of appetite. So this is expected. So again, in terms of renal dosing, um, and we will need to adjust renally if we want to use exenatide and exenatide. So, and this is one of the warnings. And for those who have gastroparesis, um, if they have it but they don't know it, by being on GLP-1 very quickly, and the symptoms of gastric paresis will surface. Same as DPP-4 inhibitor. For those who have history of pancreatitis, and also they drink a lot of alcohol, GLP-1 receptor agonist is not a good option for them. And there's a black box warning for GLP-1 receptor agonists, though. So for those who have family or personal history of medullary thyroid cancer, this is not the agent to use. So before we start, we will want to do a physical exam and include a thyroid exam to make sure that there's no such condition. And do ask the patient. And most of the agents, they're pregnancy category C, because we just don't have the data at this point. So let's compare the two classes, DPP-4 inhibitors and GLP-1 receptor agonists. So what are some advantages in each class, and also disadvantages? So I've bold and also the advantages. So for DPP-4 inhibitor, why are they good? So first, they're oral agents, so it's very convenient, and they don't really cause a lot of GI problems. And also, there's a very low risk of hypoglycemia. However, they are not that potent. So in terms of A1C reduction, probably you will see 8.7% at most, and they don't help with the weight loss. On the other hand, for GLP-1 receptor agonists, so you will see a much greater A1C reduction, as high as 1.5%. And also, they help with weight loss a lot, because some patients, they come back and they will express that they've lost like 10 pounds being on a GLP-1 receptor agonist. And it's not as convenient because they're all injectables. And many patients, they came back and expressed that they experienced some form of GI upset in the beginning, but then slowly the side effects would subside. And also, so the low risk of hypoglycemia. So the last class in the group, it's amylin mimetic. So and we don't really use this agent that much. So there's only one agent, this class. It's called pranlintide. The brand name is Simlin. What's so special about this class is that this has been approved to be used in both type 1 and type 2 diabetes patients. So the dosing can be as low as 15 microgram for type 1, and can be as high as 120 microgram injection for type 2. So how does it work? So it's similar to the GLP-1 receptor agonist and DPP-4 inhibitor. Amylin mimetic also has incretin effect, and it help with the insulin-mediated glucose uptake. So it means that um, it respond to insulin secretion. So it will help with the insulin, so we can help to reduce the insulin dose, and also it has some weight loss effect. And additionally, it would help to reduce the glucagon level. So in terms of A1C reduction, it's not that potent. So as maybe you say 0.5% reduction. Um, so in terms of side effect, two things that to keep in mind. First, nausea is one thing. The other thing is this medication can lead to severe hypoglycemia. And that's the reason when we start this agent, we will have to make sure that we reduce the insulin dose, maybe as high as 50%. So, and the insulin that we want to reduce, it's the mealtime insulin. And for those who have hypoglycemia unawareness and also gastric paresis, do not use this medication. So let's review the key concepts for the incretin-based agents. So there are three questions here. So first, in what manner do DPP-4 inhibitors and GLP-1 receptor agonists stimulate insulin secretion? Question 2, what effects do GLP-1 receptor agonists cause in managing blood glucose? 3, what effects does pramlintide cause in managing blood glucose? I will give you 30 seconds to think about the answers, and you can write them down as well. Okay, so let's take a look. Question 1. In what manner do DPP-4 inhibitors and GLP-1 receptor agonists stimulate insulin secretion? So as I mentioned earlier, this is a very important point to remember. They both secrete insulin in a glucose-dependent manner. What effects do GLP-1 receptor agonists cause in managing blood glucose? So they potentiate glucose-mediated insulin secretion, and also they decrease postprandial glucose release, and they help reduce gastric emptying, and then would lead to reduce in hunger. So question 3, what effects does pramlintide cause in managing blood glucose? So it would suppress glucose release, and also it would suppress glucagon release, and it would delay the gastric emptying, then again would lead to decrease in appetite. So the next class, it's the newest class of diabetes medications. They're called SGLT2 inhibitors. So SGLT2 stands for sodium glucose transporter 2. So they act on the kidneys. So they would target the kidneys to lower glucose in a different mechanism, which I will get into in later. So they would work independently of pancreatic function and also liver function. So and also they can be used in patients with a long standing of diabetes who don't respond to other medications, because most of the agent that we have discussed so far depends on insulin secretion, right? But then, as we mentioned earlier, diabetes is a progressive condition, and at some point some patients might stop responding or stop releasing insulin, but then this medication would act in a different manner. So specifically, SGLT2 um, would act on the proximal convoluted tubule, and it happens that the proximal convoluted tubules, they are GLT2 um, receptors. They are overly expressed in proximal convoluted tubules. And in terms of why is it significant? Because SGLT2 receptors, they are responsible for majority of the glucose reabsorption. So they work by reducing the renal glucose threshold. So by inhibiting this receptor, that will lead to the renal glucose excretion. And we will see some weight loss because the glucose now, with this medication, is excreted through urine. So let's give you some background information. So this is a nephron. So there are some receptors. So SGLT2 and SGLT1. So in the proximal area of the convoluted tubule, you will see a lot of SGLT2 receptor being expressed. That they will help with the reabsorption of glucose. And when you get to when the urine then travel through the nephron and then the glucose is being constantly reabsorbed. So by the end of the tube, in the urine, you wouldn't see any glucose. So that is the normal function. So so in normal, for those who don't have diabetes, so as long as the threshold for glucose being excreted in the urine would be about 180 milligram per deciliter. So for those who have diabetes and this threshold is pushed higher to 240, so what that means is, so for those who have diabetes, this is an abnormal mechanism. So for those who have diabetes, they won't excrete glucose in their urine until their blood glucose level hit 240. So that means they retain a lot more sugar in their bloodstream, so that will lead to high glucose. So how do we fix that? By being on SGLT2 inhibitor, this threshold would drop from 240 to about probably less than 100. So with that effect, then when the patients urinate and the blood glucose will get excreted through urine, so that would help reduce the bloodstream's glucose concentration. This slide highlights the 4 agents in this class. They are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin. So one thing is so important that I want to highlight is before you prescribe this medication, make sure to check patient's renal function. Because in general, when we check renal function, we want to make sure this medication is safe for patients to use. However, for this class, we need to care about 2 factors: efficacy and safety. The reason is, in order for patients to get the benefit from this class, their kidneys, they have to be function at a certain level depending on the agent that you choose. So as you can see on this slide, most of them, at least the EGFR at 60, and the other would be at 45. So make sure to pay attention to this small detail before you choose an agent for your patient. The next important point I want to point out is 2 of the 4 agents have the extended indication, which I will talk more about later. this indication is to reduce the risk of major cardiovascular event. Another important point that is only apply to canagliflozin. So the Canvas trial has shown that canagliflozin has a higher risk of lower extremity amputation. So the most important thing to remember for this on a safety standpoint is if the patient has a history of any ulcer, this is not an agent for the patient. So in terms of A1C reduction, this will give around 0.8%. And in terms of specific benefits, so of course, we're looking into A1 glucose reduction. So this class of agent can lower fasting glucose as well as postprandial glucose. Weight loss would be a benefit, as well as blood pressure control and uric acid level reduction. In terms of side effects, the most that we will see would be the mycotic infection, the genital mycotic infection, and also UTI. Some patient might experience hyperglycemia, and also we might see a increase in LDL cholesterol, and also because it would help with the blood pressure management, and we will also need to make sure that this doesn't cause patients go hypotensive. So in terms of warnings and contraindications, as I mentioned earlier, we will have to make sure the patients on this medication, they have sufficient renal function to clear out the medications. So for those who have severe renal impairment, this is not the medication to use. And also we found that this medication class can also cause euglycemic diabetic ketoacidosis, and mostly the cases are seen in type 1 patients. And we need to be more careful in the older population, and also for those who have hyperlipidemia, and also whose renal function is not that well. So this is a summary table, and with just the important thing about renal function. So the next big class would impact our GI tract. There are two subgroups. The first is alpha glucosidase inhibitors and bile acid resins. So they both would help delay the absorption of glucose in our small intestines. However, this is more than just in our gut. So I will mention that later on. So let's take a look at the agents. So for alpha glucosidase inhibitors, we have two agents, acarbose and miglatol. So in terms of dosing, we would want to start low and slowly titrate to the effective dose. And for this class of medications, you will have to dose 3 times daily, and I will explain why in a bit. One thing about acarbose, the max dose is based on weight. Okay, so for bile acid resins, we have an agent called covacevilam. And there are different forms. There are tablets and also there are powder forms, and I will get to that later. For alpha glucosidase inhibitors, how do they work? They would inhibit the enzyme in the intestines, and the enzyme is called alpha glucosidase. What these enzymes do is really to break down the complex sugar into simple sugars. So by having this medication, they will slow the digestion of starch and disaccharide, so that they will lead to a decrease in the rate of glucose absorption. And also they would help lower the rate of glucose being absorbed after we eat. So specifically, this medication class is to target postprandial high. One thing to keep in mind, this is important, and especially when you do patient education. Um, if someone takes this medication and they drop low, we have to use simple sugar, glucose, to treat it. The reason is because if you, for for example, if you ingest complex sugar form, and with this medication, the sugar is not being broken down and absorbed. So for those who are on this medication, you always have to tell them to use glucose tab or glucose gel. Any glucose would be fine. And in terms of A1C reduction, you might see about point, zero point 0.7 to 0.9% reduction. Because of how this medication work, there's no weight gain, and they usually do not cause hypoglycemia if they use alone. Okay, so what are some side effects? Um, so since this medication work in our gastrointestinal tract, so most likely patient would get abdominal pain and very bad diarrhea. So for those, so in terms of warning and contraindications, so for those who have IBD, who have obstruction in the GI tract, whose renal function is not that well, who are type 1, do not use this medication. And in terms of pregnancy category, this class of agent is category B. And as I mentioned earlier, if we need to treat hypoglycemia being on this agent, we will need to treat using glucose, not sucrose or fructose. So one thing I would like to point out here is this medication is taken with first bite of each meal. The next class is bile acid resin. So there's only one agent in this class. So it's called covacevulan. In terms of A1C reduction, you might see maybe a 0.5%, so it's not that great in terms of A1C reduction. So originally, covacevulan it's invented for lipid management. So, but later on, it was found that it can also help with A1C reduction. So, how this works is by delaying the nutrient absorption that would lead to the decrease of glucose absorption after meals, and also here that will help reduce liver to produce glucose. So, as I mentioned earlier, there are different forms of this medication. So you will see tablets and you will see powder. And it's kind of brutal because for patients to take this medication because the pills are really, really big. So if you choose the tablet form for the patients, they have to take 6 tablets um, a day. Or if they don't want that, then they can do the powder form, and they come in 2 strengths. And this medication is not recommended to use as monotherapy. In terms of side effects, very similar to alpha glucosidase inhibitor. They would impact the gastrointestinal tract. So for those who have hypertriglyceridemia, we don't want to use that. And also who had history of pancreatitis, we don't want to use this medication as well. And also we have to watch out for those who have fat soluble vitamin deficiency, and we might need to be a little bit more careful. And this class is a pregnancy category B, and because of the mechanism of action of bile acid resin, so it might impact the absorption of other medications. So for those who are on this medication, we always have to check the drug-drug interaction. So the last medication here would impact the central nervous system. It is a dopamine 2 receptor agonist. So the exact mechanism, we don't really know. But we found out that it would help with to manage glucose by decreasing appetite, and it has something to do with the central nervous system effect on the dopamine receptors. And it was originally approved for Parkinson's disease, but then later on, it was found that it has an impact on the glucose level for type 2, so it was approved since 1978. So in terms of A1C reduction, we might see roughly 0.9% reduction. So this medication will help to decrease fasting glucose due to the suppression of hepatic glucose output. How do we start this medication? So we want to start low, then slowly increase weekly to a tolerable dose by the patient. So, and in terms of how to take this medication, so this medication should be taken with food 2 hours after waking up in the morning. We really don't have long-term data for this class. So in terms of side effects, one thing that we really have to keep in mind, it's this agent can lead to orthostatic hypotension. So especially after the first dose, we have to pay really attention to it. So, and it can also lead to syncope and also nausea and headache. So this medication is not for a type 1 patient, and it has a lot of drug-drug interaction. So do check for drug-drug interaction. And we have to watch for those who have low renal function and low hepatic function. And this medication is a category B, pregnancy category B. And another important point to point out is this is not an agent to use if someone is lactating, because there's some post-marketing report with stroke. So let's review some agents that we talked about. So there are 3 questions here. What class of agents can cause euglycemic DKA? Question 2. Other than using for diabetes, colesevelam can be used for what purpose? Question 3. What is the mechanism of action for acarbose and meclitol? So I'll give you 30 seconds to think about this and write down the answers. Okay, let's move on. So what class of agents can cause euglycemic DKA? So they are SGLT2 inhibitors. Other than using for diabetes, colesevelam can be used for what purpose? For lipid management. What is the mechanism of action for acarbose and meclitol? So they are alpha glucosidase inhibitor, so they would inhibit the intestinal amylase and also other intestinal enzyme, right? So, and then that would cause a delay in the breakdown of carbohydrate into glucose. That would then lead to the delaying of glucose absorption in the gut. Then that will help with the postprandial glucose absorption. So there are more questions. Okay. So which second generation sulfonylurea is not recommended to use? Question 2. Based on liver function test results, when should therapy with a TCD be withheld? 3. Which agent may cause first dose hypotension? Okay, do you have the answers? Go over the answers. So which second generation sulfonylurea is not recommended to use? It is glyburide. Based on liver function test results, when should therapy with a TCD be withheld? When the liver function test is above 2.5 times the upper limit of normal, then we don't want to use a TCD. The third question is, which agent may cause first dose hypotension? And the answer is bromocriptine, which is a dopamine 2 receptor agonist. This slide summarizes the 3 agents that have gained a new FDA-approved indication to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. And so the major adverse cardiovascular events are cardiovascular death, non-fatal myocardial infarction, and non-fatal stroke. And these agents are, as I mentioned earlier, liraglutide, empagliflozin, as well as canagliflozin. And I also put the dosing related information here. I will let you explore this yourself. So we are at the end of segment 2. So here are the agents that we've talked about except insulin. And we will move on to segment 3 and just focusing on it. Thank you for listening. Let's move on to segment 3.